Hello, this is Dr. Mark Rosen again, and this lecture is going to be Critical Care Ultrasound, a vignette. The purpose of this Critical Care Ultrasound with this first vignette is to show a real-life situation where critical care ultrasonography provided useful information that may or may not agree with your first clinical impression. In this case 1, a nurse calls you as you are about to begin rounding. Always, in my opinion, not the best of signs, to see a patient that was just transferred to the MICU. The ICU resident was going to present the case, but right now you know essentially nothing about the patient as you enter the room. And this is not exactly a rare finding in the intensive care unit. You only know a little bit. The patient seems to be about 60 years old and was just transferred from the medical ward. He's on a ventilator. The man was transferred status post to cardiac arrest on the wards. You were called on an emergency basis due to his new onset of hypotension. His vital signs show significant decreased blood pressure at 88/60, tachycardia at 110, tachypnea at 24. His pulse ox is decreased at 82%. The patient is alert and complains of mild pleuritic chest pain. He's dizzy and has shortness of breath. His lungs are clear. His heart shows a regular rate and rhythm without murmurs. His neck, no jugular venous distension. His abdomen is soft, non-tender, and with positive bowel sounds. His extremities show bilateral edema up to the ankles. So the question is, what would you do now? A fluid challenge was ordered for his hypotension, and a focused bedside ultrasound was performed while awaiting the EKG, labs, chest x-ray, and for the fluid to infuse. And at this point, I'd like to share a philosophy that I have for the use of ultrasonography in the ICU. And that's, people sometimes say, when can you use it? And to me, the answer is, anytime there's an emergency, there's always some downtime. And during that downtime, in this case, taking time for tests to come back, taking time for the IV to infuse, it's a great time to use the ultrasound to enhance your clinical knowledge and to sharpen your physical exam, because I consider the ultrasound to be useful to enhance and sharpen your physical exam. Then the question comes, what to ultrasound? So this slide illustrates two different colors, things that I feel are necessary and things that are somewhat possible. I would definitely do a pneumoscan on somebody who's on a ventilator complaining of shortness of breath and chest pain who had CPR. After CPR, I'd like to do a cardiac exam. Typically, this comes with at least 3 views: subxiphoid, parasternal long, and a 4-chamber apical. And to assess the fluid status, you can easily look at his IVC and see how plethoric the IVC is, or how empty it is, and also how much it collapses during the inspiratory-expiratory cycle. A CVP can easily be measured using ultrasonography also, bearing in mind that with the ultrasound, you can see his jugular vein 100% of the time, where clinically, you can only see it about 20% of the time. And then other things to think about: fast scan if you suspect bleeding, rule out DVTs if you suspect a pulmonary embolism. If there is a pulmonary embolism, DVTs will be present in about 50% of the cases. And if you suspect fever or sepsis, you may want to examine the liver and gallbladder. Cholecystitis is one of those hidden sources of fever in the intensive care unit. But a pneumoscan, a cardiac scan, and a scan to assess fluid status, I think, is rather important. Now, what's the time to perform these tests? A pneumoscan, when I look at most of the residents, I have time to be approximately a half minute. and that's on people who are just learning the scan. If you only do a subxiphoid view for a cardiac scan, for example, to rule out a large effusion and to get a general idea of contractility, that's very rapid, 15 seconds. 3 views took the average resident in the ICU 1 to 2 minutes. So the total scan time is approximately 2 to 3 minutes. For other additional tests, if you desire, a fast scan, depending upon the difficulty, takes our residents 1 to 2 minutes. Rule out deep vein thrombosis, depending upon the skill, is 2 to 3 minutes after the person's done approximately 5 scans. Liver and gallbladder takes 1 to 2 minutes. Sometimes the gallbladder can be tricky and take longer. The chest x-ray in this patient revealed no pulmonary edema, infiltrates, or pneumothorax. His EKG shows a normal sinus rhythm with a first-degree AV block and a few PACs. There's nonspecific ST wave changes with T-wave inversion in V1 through V4. Something to realize is that chest x-rays only have, depending upon the study, a 47 to 75% sensitivity for pneumothoraces in the supine patient. This is because air rises and is difficult to see on a supine x-ray. Most of our patients in the ICU are unable to sit in a very erect position, so the best we can hope for is a semi-recumbent view. But ultrasound has a very high sensitivity and specificity. And in the studies listed below, you can see that the sensitivity and specificity when compared to a CAT scan is in the high 90%, 98, 99%. And this is because we do the ultrasound lying down in the supine position, air rises to the top, and the ultrasound beam cannot penetrate the air from the pneumothorax. So if there's positive lung sliding, there's no pneumothorax. And over here you can see, here is a rib with a rib shadow, rib with a rib shadow. The intrapleural space here has a pleural line, and the line seems to be moving, and you can even see comet tail artifact coming off. This is no pneumothorax. As compared to over here, this pleural line is not moving. It's fairly similar, actually, to the lines up above here from fascial layers. So this patient has a pneumothorax, which one can assume is most likely from CPR in this particular patient. M-mode can be used to confirm a pneumothorax. Just drop the M-mode line here, and then you can see what is commonly known as sky, ocean, and beach. The beach or sandy component over here is from the lung actually moving, where solid components of the lung are reflecting the ultrasound beam, and the black parts of the sand are where air in the lung is blocking the ultrasound and dispersing the ultrasound beam. So you get a beachy component if you have no pneumothorax. In this patient, M-mode confirms the pneumothorax. And you note that you have the sky, the ocean, and then again, straight lines. This is really a reflection, an artifact of what's above. Some people describe this as a barcode, but there's no beach. This is a pneumothorax. So the bottom line of this case can sort of be summarized very simplistically. This patient could have had hypotension from numerous etiologies. However, ultrasound picked up the problem rapidly. There was a pneumothorax, probably from CPR and worsened by the ventilator, and that knowledge was picked up in less than 1 minute. Chest x-ray is inferior to ultrasound in the supine patient. So bedside critical care sonography provided a rapid and correct diagnosis, and then an obvious treatment plan for this emergency. Thank you for your time, and please see the next vignette for additional learning about critical care sonography. I hope this was useful.